3311 was a cooperative group trial run out of the Eastern Cooperative Oncology Group, ECOG-ACRIN Oncology Group, and it was the first large cooperative group trial to look at transoral surgery for head and neck cancer. When we designed this trial, there were open questions about how do you define surgical quality when you're opening a study across a large number of centers. And we were not actually sure what to anticipate as resection rates, positive margin rates, surgical complication rates. So it was run as a randomized phase 2 trial. But our main goal was to see whether or not people with favorable risk or intermediate risk disease who had HPV-associated cancer and underwent transoral surgery could receive de-intensified postoperative treatment because of the growing awareness that HPV-associated cancer is very treatment responsive and has a better prognosis. So the way the trial was designed, we had a group of credentialed surgeons. There was a rigorous process for making sure that people did this operation with expertise. And then the anticipation was that we'd have some patients who had really favorable risk disease, either no node involvement or single node. We'd have some people who had high risk disease and clearly needed postoperative chemoradiation. And those were people with an involved margin with extensive extranodal extension defined as greater than 1 millimeter, or who had a high number of lymph nodes involved. The trial enrolled 519 patients, and there were 50 patients who were ineligible because their preoperative staging had not been completed in the right time window. We ended up with 400 patients who were randomized. And of those, 37 were in the low-risk group, 110 were in the high-risk group, and 206 were in the intermediate risk group. Our primary endpoint was disease-free survival at 2 years, and the results were quite good. For the favorable risk group, 2-year progression-free survival was 93.9%, and that was driven by 1 local regional failure and 1 distant metastasis. In the high-risk group, the 2-year progression-free survival was 90.5%, with 3 unrelated deaths and 4 local regional recurrences and 3 cases of distant metastasis. And for the group in the middle, the patients who had either multiple nodes or minimal ENE, the 2-year progression-free survival was 95% with 50 gray and 95.9% with 60 gray. So with the same number of failures in both groups. So there was good evidence that the risk stratification criteria were appropriate in picking out those patients who were at higher risk and probably did need chemotherapy. And this was quite suggestive that 50 gray of postoperative radiation is sufficient when you have intermediate risk disease. We see this as, first of all, quite a significant achievement for the surgical community because of the credentialing process and the very high surgical quality that was reflected in this trial. And second of all, we think that it sets up a real comparison between transoral surgery followed by reduced dose radiation and, perhaps the more widely used standard of care, which would be chemoradiation, particularly for patients who have radiographic evidence of low volume nodal disease.